Everyone, welcome to our channel. Today we're going to learn a very important and very common surgical condition that is called acute appendicitis. Acute appendicitis होता क्या है, कैसे होता है, हम इसको कैसे ट्रीट कर सकते हैं, इसकी क्या कॉम्प्लिकेशन, एवरीथिंग वी गोइंग टू लर्न फ्रॉम बेसिक टिल मास्टरी, सब कुछ हम सीखने वाले हैं. If you are third year or final year MBBS student, this topic is very important from your university examination point of view as well as your NEET PG. So let's start without wasting any time. Or even if you are a patient watching this lecture, I will try my best to make you guys understand in a very simpler form. So let's start. सबसे पहले चीज अपेंडिक्स होता क्या है. Yes, we know this thing from our class 11 12 बचपन से हमें पता है. It's an vestigial organ. इसका पूरा नाम है, it's a vermiform appendix. Appendix is a narrow blind ended worm like tube. यानी it's a tube and its one end is closed. It is arising from a posterior medial wall of cecum. जो हमारे लास्ट इंटेस्टाइन का सीकम है उसके posterior medial wall पे it is arising there. There is a wall between ileum and cecum that is called ileocecal wall and it is 2 centimeter below it. अब अपेंडिक्स की बात करें, अपेंडिक्स में दो चीजें होती है. एक तो अपेंडिक्स का बेस है, अपेंडिक्स की डीप है. फर्स्ट विल टॉक अबाउट बेस ऑफ द अपेंडिक्स. The location of the base of the appendix is constant. So if you open any abdomen and if you locate this structure, you're going to find a base of the appendix. Where? So there is a muscular band running along the large intestine that is called tinea coli. Where these three muscular bands, these tinea coli converge, where they meet, that will be the location of the base of appendix. Now question arise, like हम abdomen खोलना नहीं है, हम base of the appendix externally हम कैसे locate कर सकते हैं? So at the time we have to remember the McBurney's point. McBurney's point is a point where you're going to locate the base of appendix. And now how are we going to locate McBurney's point? So we have to draw a line from umbilicus to right side anterior superior iliac spine. We draw a line. For example, this is your line, this is your umbilicus, this is your anterior superior iliac spine. We draw a line. We divide this line in a 3 equal part, 1 2 3, such that 1/3 and 2/3, the point 1/3 and 2/3, that will be our McBurney's point. 1/3 from your anterior superior iliac spine and 2/3 from your umbilicus. This junction, this point is called McBurney's point. Now question arises, why it is important? Yes, the base of appendix is located over there. But in case of the acute appendicitis case, you're going to find a maximum pain and tenderness at this point. And the clinical sign is called pointing sign you're going to find. So after talking about the base of the appendix, now let's talk about the tip of appendix. Before we talk about the tip of the appendix, we must know what are the changes happening to the appendix after the birth. Then afterwards we can understand the position of the tip of the appendix. So during the birth, after the birth, the appendix is short and broad. Appendix बहुत short होता है, broad होता है. We can't differentiate कि junction कहाँ पे है. Appendix and cecum के बीच में जो junction है वो हमें पता नहीं चलता. There is no clear junction. By the age of 2 years, this appendix from short and broad will start becoming a narrow and tubular structure. And as later on childhood, when the cecum grows and there is a rotation of the cecum, this tip of the appendix will have a different position. So let's learn this position. So first, if it is ahead of the ileum, we call it pre-ileal. If it is behind ileum, we call it post-ileal. This 1 o'clock, 2 o'clock position is nothing just like a clock. Clock के अंदर क्या होता है 1 o'clock, 2 o'clock position. Similarly, if it is anterior to the ileum, we call it pre-ileal. If it is behind the ileum, we call it post-ileal. If it is going towards the pelvic, we call it pelvic position. And if it is below the cecum, we call it subcecal. And if it is behind the cecum, we call it retrocecal. Understood so far? Yeah, I remember like there was one MCQ in a previous year NICT NEET PG in which they have removed this name and they were how to we have to match it कि कौन सा है, we have to just match it. So from exam point of view एक बार ये याद कर लेना is very easy. And if we talk about Indian population, the retrocecal position is very common we're going to find. So after talking the base and tip of appendix, now let's talk about the blood supply. So appendix is derived from the embryological midgut, and we know the organs which are developed from embryological midgut are supplied by the branches of superior mesenteric vessel. But now कैसे ये appendix को हम supply करेंगे blood supply? So superior mesenteric artery will give a branch called ileocolic artery. This ileocolic artery will divide into two parts: superior division and inferior division. The inferior division of ileocolic artery will supply appendix. how it will inferior division of ileocolic artery will give branch, that will be appendicular artery. This appendicular artery will run in a mesoappendix and reach to the appendix. And this artery, appendicular artery, is an end artery. Secondly, there is no collateral supply to the appendix. अब इसका significance क्या है? For example, if there is thrombosis in this artery, as it is an end artery, there is no collateral circulation, it will lead to ischemia, necrosis, and gangrene. As a result, there will be gangrenous appendix. It's an emergency condition. Now, after talking about the arterial supply, let's talk about venous supply. Similar to the arterial, इसमें भी same है. So venous will be ileocolic vein, then it will go into the superior mesenteric vein, and in the end it will reach to the portal vein. Understood? We talk about the base, we talk about the tip, we talk about the blood supply. Now coming to our main topic, inflammation of appendix, appendicitis, acute appendicitis. ये होता क्या है, कैसे होता है, सब कुछ हम easily जानने वाले. Starting with the etiology. एग्जाम में ऐसे ही लिखना है, etiology, organism, pathogenesis, treatment modalities, complications. ये हमारा एग्जामिनेशन का फॉर्मेट होता है. So starting of etiology, appendicitis किस में ज़्यादा देखने को मिलता है? First, the common cause of this appendicitis is because of the fecalith. Question: fecalith क्या है? So it's this stool which got hard, the fecal material which become hard and obstruct the lumen of appendix. That is our fecalith. It is more seen in young male compared to female. Young male में ज़्यादा देखने को मिलते हैं. And rich fiber diet prevent appendicitis. Because the obstruction lead to the appendicitis and rich fiber diet prevent the obstruction. Third, it is by the studies it is seen that the white race is more affected compared to the different race. So after etiology, what are the organisms which are causing this appendicitis? It's an inflammatory condition. Yes, it's going to be a bacterial infection, but कौन से bacteria? We're going to have most common is E. coli, then Enterocoli and Streptocoli. Mostly around 80 to 90% we are going to find the E. coli only, and rare like 30%, like 20-30%. It's a range. Now talking about the types, दो types के होते हैं, obstructive cause and non-obstructive cause. So obstructive and non-obstructive नाम से हमें पता चलता है अगर appendix का lumen block हो गया and which is leading to the inflammation, that is we call it obstructive appendicitis. If there is no obstruction and leading to the appendicitis, we call it non-obstructive cause. So what are the things which can cause obstruction? Fecalith, food particle, roundworms, adhesion and kinking in case of the carcinoma of colon. And non-obstructive, we call it cathedral. It is more seen in children, and only 10 to 15% of total cases it will be non-obstructive. So most common obstructive होता है. Obstructive में सबसे common fecalith. Now सवाल आता है, yes, obstruction से appendicitis हो सकता है, but कैसे? बहुत बार हमारे प्रोफेसर भी बोलते हैं कि if we don't treat appendicitis it will lead to peritonitis. कभी सवाल नहीं आता है कैसे, क्यों, क्या पूरी जर्नी क्या होती है, कैसे ये पैथोजेनेसिस क्या है, ये हम सवाल पूछते नहीं है बहुत बार. So we're going to learn this. First we're going to learn about non-obstructive. So in non-obstructive there is no obstruction of the appendix initially. The infection spread from somewhere else, यानी large intestine या small intestine से ये infection spread होता है and that reach to the appendix, and that will lead to the secondary infection without obstruction, and that will lead to the acute non-obstructive appendicitis. अब चलो appendicitis हो चुका है, non-obstructive है, आगे जाके इसका आउटकम क्या हो सकता है? फर्स्ट आउटकम ठीक हो जाए, रिजॉल्व हो जाए. सेकंड, रिजॉल्व होने के बाद फिर से आ जाए, we call it recurrent appendicitis. If appendicitis is recurring at higher frequency, it will lead to the fibrosis. If there is fibrosis, it will lead to the obstruction eventually. So non-obstructive appendicitis भी हो, but हम इसको treat नहीं करेंगे, आगे जाके it will lead to the obstructive only. Now we coming to our main obstructive appendicitis. होता क्या है इसमें? How obstructive appendicitis lead to the peritonitis, हम इसमें देखने वाले. So if this is appendix, इसका lumen block हो चुका है. This is blind ended. एक lumen तो एक side block किया, एक side block हो चुका है. If there is luminal blockage from any reason, fecal teeth, worms, foreign body, food particle, from XYZ any reason, if there is obstruction, सच दैट एज अ रिजल्ट जो हमारे म्यूकस या इंफ्लामेटरी फ्लूइड्स जो अंदर सीक्रेट हो रहे हैं या लुमेन के अंदर जो भी सिक्रेशन हो रहा है वो आप बाहर नहीं जा सकते. So there will be the accumulation of this inflammatory and mucus inside it. This accumulation will increase the intraluminal pressure. If there is the increase in the intraluminal pressure, it will block the lymphatics and venous drainage. If lymphatics and venous drainage are blocked, it will lead to the edema of the mucosa and wall. If there is edema and of the wall, it will lead to the ulceration ischemia. If there is the ulceration, the break in the continuity of epithelium, this bacteria can translocate to the different layers of the our appendix. So there will be the bacterial translocation. It will spread from mucosa to submucosa and muscularis propria, and it will lead to the condition acute obstructive appendicitis. If it is not treated, it can lead to the thrombosis of appendicular artery. When the appendicular artery is blocked, it will lead to, yes, eventually it will lead to ischemia and necrosis, and it will, the full thickness wall of appendix will be necrosed, and it will lead to financially gangrene, and gangrene of the appendix can burst, and it can perforate and lead to the condition peritonitis. So this is the reason why reading standard textbook is very important, because many other platform will just tell you, okay, if you don't treat acute appendicitis it will lead to peritonitis, but how MCQ solve हो जाएंगे, but concept नहीं build होते हैं. So this is the entire flow chart, ये कैसे peritonitis करते हैं. And I have drawn this structure to just make you guys memorize it. Don't draw in your examination, just to memorize ये कैसे होता है. देखो ये इंटेस्टाइन का लुमेन मैंने बनाया है, अपेंडिक्स का लुमेन बनाया है. Luminal obstruction, increase in intranominal pressure, blockage of lymphatics and venous drainage. It will lead to edema. Edema will result into ulceration. Ulceration will lead to the, it will allow the bacteria to translocate to different layers, submucous and muscularis. That will be full thickness appendicitis will happen. And if there is a blockage of the appendicular artery, that will lead to the ischemia and necrosis, and the full thickness necrosis and the wall of and there will be perforation, and that will eventually lead to the peritonitis. This was the entire pathogenesis. Non-obstructive, we understand non-obstructive eventually lead to the obstructive, obstructive eventually lead to the peritonitis. Entire journey we have understood so far. Hope you are following. नाउ टाइप्स हमने देख लिया, एक तो ऑब्स्ट्रक्टिव कॉज हो सकते हैं, नॉन ऑब्स्ट्रक्टिव. इसको लाइक अकॉर्डिंग टू एसआरबी वी हैव टोटल 5 टाइप्स ऑफ acute appendicitis. First is a non-acute non-obstructive appendicitis, cathedral appendicitis, हमने जो पहले बोला था वो, which eventually lead to acute obstructive appendicitis. If we don't treat a non-obstructive, it can recurrent. We call it recurrent appendicitis. We have a milder form इसमें जितना पेन एंड इतना प्रोग्रेशन होता नहीं है, we call it subacute appendicitis. And after the surgery, if there is a long stump of appendix is left, that can again go to inflammation, and that is called stump appendicitis. It is seen in laparoscopically when we remove the appendix and the stump is retained. That goes under the inflammation, and we call it stump appendicitis. Understood? Total 5 types. Now, clinical features. Uh, we are in a, for example, imagine you are in a hospital or in a OPD, a patient comes to you. How are we going to diagnose के, like how are we going to think कि इसको appendicitis है कि नहीं? What are the symptoms? So there are a triad called Murphy triad. There will be first, there will be pain. अब pain कहाँ पे होगा, कैसे होगा? Pain initially will be at the periumbilical region, near the umbilicus. अब क्वेश्चन आता दिमाग में, अपेंडिक्स राइट इलैक फोसा में, अब वहाँ से अम्बिलिकस में क्यों पेन आ रहा है? Because when there is the appendicitis, there will be distension of appendix, and first there will be visceral pain. This visceral pain later on will be towards the right iliac fossa, and that will be our somatic pain. That will be because of the inflamed appendix pain. Second, there will be nausea and vomiting. Vomiting because of the pyrospasm, and there will be fever. Obviously, it's a bacterial infection. We're going to have a fever and anorexia. This was the symptoms. Now we're going to learn about the signs. So clinical signs we're going to evaluate. If you ask patient like point out कहाँ पे pain exactly आपको सबसे ज़्यादा हो रहा है, he or she going to point out at the McBurney's point. I already mentioned in this initial starting of the lecture McBurney's point. हम कैसे हम इसको surface marking करते हैं. So at the McBurney's point, we're going to find the maximum tenderness and rebound tenderness. That is called as pointing sign. Second sign is rosing sign. In rosing sign, if we press on the left iliac fossa, and patient going to feel the pain on the right iliac fossa. But क्यों? We are pressing on the left, but still why he's having pain in the right? So because when we press on the left, there will be shift of the bowel, and that bowel shifting will irritate the parietal peritoneum. That's why there will be pain in the right side. Third is the bulbing sign. In bulbing, it's a positive in a retrocecal appendix. When legs are raised, patient complain of the pain while pressing over the flanks. Bulbing के अंदर हम leg raise करेंगे and flanks पे हम जब pressure करेंगे, he will going to feel the pain. Now we're going to talk about psoas sign or Cope-Psoas test. In Cope-Psoas test, what we do, we flex the right hip against the resistance. If you can see in this photo, we tell the patient to flex and we are providing the resistance. And there will be the pain in the right iliac fossa. Obturator sign. Obturator sign when patient going to feel pain when you are flexion and doing the internal rotation of the right hip. When we are flexing and doing the internal rotation of right hip, patient going to find pain. And there are some non-specific tests like Dunphy sign and Aaron sign. In Dunphy sign, when there is, it's like our cuff, impulsive cuff test. Similarly, a patient will feel pain while cuffing. And Aaron sign, there will be pain in the epigastric while pressing in the right iliac fossa. So we understand this sign so far. Rule fine sign. First was our pointing sign. McBurney's point. Second was rousing sign, at where when we are pressing on the left side, we're going to find the pain in the right side. Left में press करेंगे, right में हमें pain feel होगा because of the shift of the bowel. Bulbing sign हम raise करेंगे, हाँ और patient को flanks के ऊपर हम press करेंगे, leg raise करके flanks के ऊपर press करेंगे, patient going to find the pain. Psoas sign we are providing resistance. And obturator sign. Now we're going to talk about some specific sign which we're going to find on the base of the location of the tip of the appendix. If the tip of the appendix is retrocecal, which is the most common position of the tip of the appendix, we're going to find psoas test positive, psoas sign positive. There will be no abdominal rigidity, and if we tell the patient to flex the right leg, the pain will decrease in case of the retrocecal. In case of the pelvic, as the appendicular tip is towards the pelvis, the bladder is over there, it can irritate the bladder, that can increase the micturition, that will increase the frequency of micturition, and it can also irritate the rectum and it can lead to the diarrhea, pelvic diarrhea. And obturator sign will be positive in case of a pelvic position of the tip of the appendix. And in case of the post-ileal, it is least common position which we can find of the tip of the appendix, and it is hard to diagnose because all these signs which you have studied so far, these all five signs will be absent in case of the post-ileal position of the tip of the appendix. Now let's talk about imaging and how we're going to confirm our diagnosis. So when we do our blood reports, we're going to find the increase in the leukocyte count, increase in neutrophils, and increase in the CRP. Yes, as it is an inflammatory condition, we're going to find all these three indicators will be elevated. Now imaging, we have 2-3 options to do, but what are the investigation of choice? Which investigation we're going to do in a specific patient? First, if it is a children, we're going to perform USG. In adults, we can perform CECT. CECT is imaging of choice, investigation of choice. Usually we do USG, but CECT is the investigation of choice. Third, in case of the pregnant woman, we can't do CECT. We use USG or MRI. And MRI is more preferable in case of pregnant woman because of the pregnancy, the USG finding could be inconclusive. What could be the USG finding in case of appendicitis? First, we can find non-compressive and hyperechoic thickness of appendix. We can either it could be appendicocolic, periappendicular fluid could be present, and interruption of the submucosal continuity. This could be USG finding. There is a score called Alvarado score, also called as the Montreal score. This score is a highly negative predictive value. इसका मतलब क्या है? हाईली नेगेटिव प्रिडिक्टिव वैल्यू। अगर स्कोर कम आ रहा है, इसका मतलब कि एपेंडिसाइटिस के होने के चांसेस बहुत कम है। अगर स्कोर हाई आ रहा है, इसका मतलब कि एपेंडिसाइटिस होने के चांसेस ज़्यादा है, पर हम इसको कंफर्मेटरी नहीं बोल सकते। वी हैव टू डू इन्वेस्टिगेशन, वी हैव टू डू इमेजिंग टू कंफर्म अवर डायग्नोसिस. So what is Montreal score or Alvarado score? First is a M for migration of the pain. पेन माइग्रेट होगा पेरियम्बिलिकल टू राइट इलियाक फोसा, जिससे हमने पहले स्टार्टिंग में हमने याद किया था. यस, सो माइग्रेशन ऑफ पेन, एनोरेक्सिया, nausea, tenderness, rebound pain, elevation of temperature, leukocytosis, shifting of the blood, white blood cell count towards the left. This is the score. याद रखने की इतनी ज़रूरत है, रखने की ज़रूरत नहीं है, रखने की ज़रूरत है, बिकॉज एग्जाम में बहुत बार पूछ लेते हैं एमसीक्यू के अंदर. नाउ डिफरेंशियल डायग्नोसिस कि कौन कौन सी कंडीशन हो सकती है. इफ एपेंडिसाइटिस नहीं है तो कौन सी दूसरी कंडीशन हो सकती है. सो आई हैव डिवाइडेड इन द बेस ऑफ लाइक इन चिल्ड्रन, अडल्ट और अडल्ट फीमेल. हम थ्री डिफरेंशियल डायग्नोसिस हम एज ग्रुप एंड जेंडर के अकॉर्डिंग हो सकते हैं. इफ इट इज चिल्ड्रन, we can either have mecal diverticulitis or intussusception या mesenteric adenitis could be present. In case of the adult lady or adult patient, ureteric colic, bowel obstruction, torsion, gastroenteritis could be the differential diagnosis. In case of the adult female, it could be the mid cycle ovulatory pain, ectopic pregnancy, ovarian cyst torsion. These are the differential diagnoses. Moving further, हाउ वी गोइंग टू मैनेज दिस पेशेंट. हमने अब तक देख लिया कि अपेंडिक्स क्या है, अपेंडिसाइटिस क्या है, ऑब्स्ट्रक्टिव क्या है, नॉन ऑब्स्ट्रक्टिव क्या है, कौन सी क्लिनिकल साइन हमें मिल सकती है, इस इन्वेस्टिगेशन हम कैसे क्या कर सकते हैं, स्कोर कौन सा है. अब हमने डायग्नोस कर लिया कि यस अपेंडिसाइटिस है. अब मैनेज कैसे करेंगे इसको? डेफिनेटिव इसकी एक ही ट्रीटमेंट है, अपेंडिसेक्टोमी. अपेंडिक्स जो इन्फ्लेम है उसको हमको रिमूव करना है. हम इसको टू तरीके से हम रिमूव कर सकते हैं. फर्स्ट इज ओपन सर्जरी एंड वन इज लेप्रोस्कोपिक सर्जरी. बट फॉर एग्जांपल एक केस सिनेरियो है, पेशेंट इज अनफिट फॉर सर्जरी, तब हम क्या करेंगे? इन दैट केस वी विल डू अवर कंजर्वेटरी ट्रीटमेंट. वी गोइंग टू मेक द पेशेंट नील पर ओलर, एनपीओ करेंगे, आईवी फ्लूइड्स देंगे, IV एंटीबायोटिक. अब IV एंटीबायोटिक शुड बी कवरिंग बोथ एरोबिक एंड एनारोबिक and painkillers. That will be our conservative management. And there are two modalities. One is the open appendicectomy and laparoscopic. Let's start with the open. ओपन सर्जरी में हम कौन कौन से इंसिजन हम दे सकते हैं वो हम याद करेंगे. देखो, मैकबर्निस इंसिजन जो मैकबर्निस पॉइंट पे हम दिया जाता है, उसमें दो टाइप है, ग्रिड आयरन एंड रदरफोर्ड मॉरिसन. ग्रिड आयरन के अंदर देयर विल बी मसल स्प्लिटिंग, मसल को हम स्प्लिट करेंगे. इन रदरफोर्ड मॉरिसन इंसिजन वी गोइंग टू कट द मसल्स. In case now we talk about lens or modified McBurney's incision. In modified McBurney's incision, we give incision along the skin crease. So cosmetically ये ज़्यादा अपीलिंग है क्योंकि दिखने को नहीं मिलता है कि कहाँ पे इंसिजन लगाया था, because it get hidden behind the skin crease. Also called as bikini incision भी हम बोलते हैं, बहुत लोग ऐसे स्किन क्रीज के अंदर देते हैं. थर्ड इज a lower midline. Lower midline incision कहाँ पे देते हैं? In case of the perforation we give lower midline. अब कौन कौन से स्ट्रक्चर हम वी कैन एनकाउंटर व्हेन वी आर परफॉर्मिंग appendectomy open. We're going to find skin, superficial fascia, also we're going to find scarpa fascia, Kemper fascia, external oblique epineurosis, all muscles. Then we're going to find the preperitoneal fat and peritoneum. These are the structure we're going to encounter when we are performing appendectomy. Now, in case of the laparoscopic, we have three ports we made. First is infraumbilical, second is left iliac fossa, and third is the suprapubic. So, what are the steps? अब appendectomy के steps क्या होता है? First, locate करना है. Locate कैसे करेंगे? Starting में मैंने बोला था tinea coli muscle. So, where the junction of the three tinea coli muscle, that is the base of the appendix, हम locate करेंगे. We going to ligate the appendicular artery. जो meso appendix में से आती है, appendicular artery को हम ligate करेंगे. Now what we're going to do, we're going to crush the base of the appendix. We're going to transfit the base of the appendix. Then we're going to cut the appendix. Then we're going to close all the layers of the abdomen जो हमने open किए थे, वो we're going to close all the layers. Now what could be the complication of this surgery? So that can be we can have bleeding, So now, what could be the complication after the surgery or during the surgery? No, cut 3, 2, 1. So what could be the complication in case of the appendicular surgery? It could be bleeding from appendicular artery, wound infection can be happening, injury to the iliohypogastric nerve. This nerve injury can lead to the increase the risk of the right inguinal hernia or pelvic abscess. So these are the complications which can happen in case of the appendicectomy. So thank you so much. If you have any doubt or any queries, you can comment down. There are some topics which are left in this appendix module. There are scenario like what we're going to do in case of the appendicitis in case of a pregnant woman. What are the treatment modalities? So ये सब हम next video lecture में बात करेंगे. I hope you understand so far. I'll revise in the end. Just give me your 2 minutes. I'll revise what we have studied so far. We understand the anatomy. We understand the position, base of the appendix, deep of the appendix, development of appendix with the along with the age. We understand the pathogenesis, obstructive, non-obstructive, what are the causes, etiology. We understand the clinical features, Murphy's triad. We are also understand the signs, all the 5 signs. We understand the Alvarado score. After the Alvarado score, we understand the management, conservative and surgical. In surgical management, we also understand the about both open and laparoscopic and complication we have understood so far. So thank you so much for watching this video lecture. I hope you understand. And if you have any doubt, any queries or any suggestions, please comment down in the comment section. And have a nice day. Keep studying.